One. So please start. We are live.
A very good evening to all. My name is Dr. Kamal. I am head of Department of Medical Affairs at Ajanta Pharma. On behalf of Ajanta Pharma, I welcome all of the respected faculty members and the delegates on edition 2 of Cardio Master Workshop. This is the third in this series of edition 2. On behalf of Ajanta Pharma, we salute all of the doctors who have been true warriors in the current pandemic battle. A very big thank you all doctors from our side, sir. And as a recognition to our small bit towards fight of COVID, Governor of Maharashtra has appreciated Ajanta Pharma as well. And we are proud to announce that we have introduced more than 150 products which are first to market in India in last 10 years. And we are spread across 4 continents in 30 plus countries with the strong team of 6,500 plus Ajantaites. Along with that, we also have 2 US FDA approved units in India and 8 state-of-art manufacturing facilities in India and Mauritius. With our strong trust on R&D, we have a strong team of 750 plus scientists who are working across state-of-art facilities with complete value chain. And we have a very strong presence in cardiology and diabetology. Along with that, we have a strong presence in ophthalmology, dermatology, and pain management. With this, this is the agenda for today's meeting. Interesting echoes in congenital heart disease. Speaker and presenter would be Professor Dr. Anita Saxena, moderators Professor Ajay Mahajan and Professor Dr. Milind Phadke. We have expert panelists Dr. I.B. Vijayalakshmi and Dr. Nageshwara Rao Koneti. Along with that, postgraduate students from all across India, Dr. Sriram from LTMC in Mumbai, Dr. Sunil Dighe from JJ Hospital Mumbai, Dr. Sunil Mondal, GB Pant Hospital, Dr. Abhik Haldar from SCBMC Cuttack, Dr. Umesh Tripathi from SGPGI Lucknow, and Dr. Sandeep Sharma, SMS Medical College, Jaipur. So Dr. Ajay Mahajan is a professor and head of Department of Cardiology at GS Medical College and KEM Hospital. Dr. Milind Phadke is additional professor at Cardiology, LTM Medical College and LTMG Hospital, Sion, Mumbai. Presenter, Professor Dr. Anita Saxena heads the Cardiology Department at AIIMS, Delhi. Dr. I.B. Vijayalakshmi is Senior Consultant of Pediatric Cardiology, Bangalore, and Dr. Nageshwara Rao Koneti is a Senior Pediatric Cardiologist based at Hyderabad. So with this, without taking much time, now I would request our moderators, Dr. Ajay Mahajan and Dr. Milind Phadke to kindly kickstart the meeting. Dr. Mahajan, sir, over to you, please.
Respected members of today's program. So today is the biggest feast for all PG students because they are going to get biggest inputs from Dr. Professor Anita Saxena madam and Dr. Vijayalakshmi madam and Dr. Nageshwar Rao. So there is, I will request Dr. Milind to introduce Dr. Anita madam and Dr. Vijayalakshmi madam and Dr. Nageshwar Rao and start the proceeding. Over to Dr. Milind.
Thank you, sir. But sir, I feel that today's panel really needs no introduction because we have the doyens, the pioneers and trailblazers of pediatric cardiology in India today. So Dr. Anita Saxena madam, the head of Department of AIIMS Hospital Cardiology till recently, Dr. Vijayalakshmi madam, the ex-HOD of Jayadeva Institute, and Dr. Nageshwar Rao, sir, very senior interventionist and renowned pediatric cardiologist from Hyderabad. So it's really a pleasure. It's going to be a learning feast for the next 1 to 1.5 hours. And we have students participating from all corners of the country, and we have a very big audience as well. And this is the third such program, so we are also grateful to Ajanta for this idea. And I will not take any further time, and without much ado, I will hand over to Dr. Anita Saxena ma'am. And now we are all in for a big treat. Thank you.
Thank you, Dr. Milind. Thank you, Dr. Mahajan. I would like to begin by thanking Ajanta Pharma, specifically Mr. Agarwal, Kanu Agarwal, who's been a pioneer in arranging this session. I hope I'm able to come to your expectation. I would try and show some interesting echoes, and I would want the students. I can see Abhik Haldar, Sriram, Iswaran. Who else is joined? Dr. Umesh.
Yes, ma'am.
do we have anybody else? Because it will be easier if I sort of, ask one of you rather than leave it open. Let me start. So I was head of the department till recently, and now I have joined PGIMS, Postgraduate Institute of Medical Sciences at Rohtak. So very easy one to begin with, a still image. Whosoever wants to go for it, please.
Is it a Chiari malformation now?
Very good. Absolutely Chiari malformation. And I would just want to ask you if you know a little bit more about Chiari malformation. What is its significance? We often see it in, even in adults, I would say, but a little more about it.
Ma'am, there is it can be a confusing element sometimes by because cord triatrium dexter can also be present like this on echocardiographic. Plus during surgical corrections also it can hinder.
No, let's stick to echocardiography. How do we recognize that this is Chiari malformation and not anything else?
It does not have any color flow turbulence over it.
But then sometimes cord triatrium dexter also is non-obstructive. We know that. So what kind of a view you should do to be sure? Like, the image that we have on this side looks almost like cord triatrium dexter. So you should actually be looking at its origin.
Subcostal view looking from the IVC and then the entry into the array will be helpful.
Yes, so it is often connected at the IVC junction, and it can be very big, but in some people, but mostly it is quite small. A small one you would see in very many echoes, but a big one sometimes so big that it can cross the tricuspid valve, even the pulmonary valve. I've seen one where it even went up to the pulmonary valve, but absolutely of no significance, except that some, cryptic strokes are being blamed onto small clots on the Chiari network. Dr. Lakshmi wanted to say something.
Yeah, I agree with Anita, whatever she's saying. The one on this left side, it looks like divided right atrium. Bob Anderson would like to call it as divided right atrium rather than cord triatrium dexter. And one thing you must see that this is the Thebesian valve. And from the Thebesian valve, if it comes across like this and it joins completely, then it is a divided right atrium. But if it has got a, bizarre movement and it is moving, that is the Chiari network and it doesn't go across. And as Anita already said, this divided right atrium can be fenestrated or not fenestrated. If it is not fenestrated, then there will be thrombus formation. If it is fenestrated, then there will be flow. So for that, you have to do the contrast echo and inject the bubbles from the upper limb and the lower limb to find out whether the fenestration is there or not. So the one on the right side, what Anita is showing is the Chiari network, because you can see that it is moving like that, the free dance of the Western thing. Whereas the divided right atrium membrane, it doesn't move that much, unlike the Chiari network. And the Chiari network is physiological and divided right atrium is pathological. So that is the distinction you have to do. And Dr. Anita asked you which view you would like to do. So the RV inflow is the best for looking at the divided right atrium. And for Chiari network, of course, subcostal view, 4-chamber view is enough. Okay.
So just to add a little bit, you should be seeing it in most of the cases originating at the IVC junction. So a subcostal view where IVC is being shown would be the best way to track it down, whether it is Chiari network or not. And Chiari is the name. Some people like to write it as Chiari, because the person who described Hans Chiari or Chiari was the one whose name this has been made. And I mean, this has been named, and he was a Austrian physician, and he described it long time ago, 1897, if I'm correct. So it's a very, very old thing but we should know about it. Okay, this is another very simple one. I don't think there should be any question about the diagnosis, but still, for the sake of completion, let's say what is it?
And this is an apical four-chamber view.
Ma'am, it is
Showing dilated
anomaly.
area and it's with the.
No, one student can answer it.
Let Umesh, let somebody else answer this one. Yes, please go ahead.
Ma'am, this is an apical four-chamber view showing a displaced septal tricuspid leaflet and long and flail movement of the anterior tricuspid leaflet, suggestive of Ebstein's anomaly.
Okay, good.
And
So,
in the color Doppler view,
color Doppler.
In the color Doppler view, we can see that there is significant moderate to severe tricuspid regurgitation.
Mm-hmm. So, at a level of DNB or DM,
there is also some amount of.
Would you like to say something more?
Some amount of?
Please complete your sentence. Some amount of.
I think your audio is okay.
I think there's some issue about. Umesh, you can go ahead.
There is, as described, there is apical septal apical displacement of septal leaflet. It is suggestive of Ebstein's anomaly, and there is also some dilated coronary sinus that I can see. Plus severe TR.
Can you, from the TR jet, can you say the velocity of TR jet? Can you guess if it is a low velocity or a high velocity TR?
Ma'am, it's
ma'am, it appears to be a
high velocity TR. It's high velocity TR, which is not a feature of Ebstein's high pressure TR. Seems.
So if you have a little high velocity TR jet, I don't know what the velocity is because we are not measuring it right here, but going by the fact that it's a bit of a turbulence here, you can expect it to be little high velocity. But tell me, if it's really little high velocity, what would you like to think in terms of association? Why should velocity be high in an Ebstein's?
Is there some amount of obstruction to the RV outflow?
Yes, so you have to think about pulmonary stenosis.
Anterior tricuspid leaflet.
No, not because of tricuspid leaflet, but as it is an association known between pulmonary stenosis and Ebstein. Of course, rare, but you must keep that in mind. It's, of course, very small children or neonates would also have a high velocity TR. Yes. But if it is an older child or an adult, think this is an adult, you have to think of association with some pulmonary stenosis. And in patients with severe TR, your severity of pulmonary stenosis may actually be a little underestimated because of severe TR. There's not much flow happening across the pulmonary valve. The other association that you should look for is, what is this equal to? This is a subcostal view.
Atrial septal defect is there.
Atrial septal defect.
What is the shunt?
We can
the left to right shunt, sir.
Why do you say left to right?
Ma'am, the video is not. It's moving.
Oh, I see. Oh, you're not able to see the video.
It's
Nagesh,
bidirectional. It's bidirectional.
See the shunt. I can see that. See the shunt.
Yes, ma'am. It's.
What is that?
You expect often it to be bidirectional. Of course, it can be left to right, but this is not even a large AC. It is more like a PFO or a little bigger than PFO. But you can see that it is actually going more right to left. It's more blue than red. I don't know if it's visible to you or not.
Yes, ma'am, it's visible.
Yeah, so it's important to know because these patients may actually be little cyanos because of right to left shunt. Dr. Nageshwar, would you like to add anything to it?
Yeah, see the first ECG. The ECG is showing a tall P wave. Can you see that?
Yeah.
With reference to the QRS axis. QRS. See, second is in Ebstein's, you can see the STL, PTL will be involved. Here, STL is very well profiled. If you want to see PTL, you have to go posterior sweep where you will see corner sinus. ATL is very much elongated. So you can have an isolated PTL displacement as well. So how to actually do the prognosis in this case? Ma'am asked a wonderful question. The velocity of the TR. So all patients of Ebstein's by and large will have normotensive TR or low pressure TR. If you have high pressure TR, number one, you have to suspect the pulmonary stenosis or if there is ventricular septal defect. In neonate, if you see, that is going to give you a lot of prognostication. In neonate, baby is born and you are seeing TR velocity is high. Okay, what is the prognosis? Is there any scoring system for the Ebstein's anomaly in terms of prognosis?
Goose score, sir.
Goose score. Do you have any idea?
Yes, sir. We total the right atrium plus the atrialized RV divided by the total left system, sir.
Okay. Okay. Do you, if you are asked to do a cardiac catheterization, I did during my post graduation, we did once. So if you are taking a pullback from right ventricle to the right atrium, what kind of a catheter you use and what are the hemodynamic and electrical observations you see?
Sir, the electrical observations that I see, I don't know, is all that the RA and the atrialized part of the RV.
What catheter would you use? Would you tell that first?
It's not available nowadays.
Yeah.
No idea, sir.
I think these students would not have seen it also, and
Yeah.
I don't think my lab also has it. So
Yeah.
they used to be very special. Yeah.
It's called a Zucker catheter. Now what you can do is you can take a wide bore catheter, that is either guide catheter or sheath, and put the electrode through that and take a simultaneous pressure and the electrical ECG, electrocardiogram. Then you will see the right ventricular pressure and right ventricular electrocardiogram. Then you will see right ventricular electrocardiogram, but right atrial pressure. Then if you do further pullback, then you will see right atrial electrocardiogram and right atrial pressure. So people used to ask all this in the exam, but you should be aware of that.
Okay, thank
So
you.
can I add one point, Anita?
Yes, please go ahead.
As Dr. Nageshwar Rao said, the tall peaked P waves, and they were called as Himalayan P waves. Do you know who named it as Himalayan P wave? Umesh?
No, ma'am.
It is Helen Taussig, the mother of pediatric cardiology. She called them as Himalayan P waves. And Anita, there is a question by Dr. Rahul. He asked, what is the criteria to differentiate between the PFO and the AST?
Okay, so Dr. Rahul, the PFO is much smaller than AST, but generally we would say if there is any gradient across this defect, then it is likely to be a PFO, because PFOs are small, but if there is no gradient, it is usually an AST. Having said that, a lot of people will say anything less than 5 millimeter in an adult, 3 millimeter in a newborn would be a PFO, and anything bigger than that would be an AST. And AST or PFO is present in practically all patients of Ebstein's, 90%, but AST, a large AST, would be present in about 60 to 70, 2/3 of patients or so in Ebstein's anomaly. So let's go on to move on to the other one, next one. Oops.
Yes, ma'am.
Let's see. Okay.
Very good case.
So this is, I don't know, a lot of adult colleagues may not be very comfortable with so-called upside down view. We as pediatric cardiologists often use this view, but I can only tell you that this is like a long axis. It's actually an apical 5-chamber view. The right side is not well seen. This is left ventricle, this is left atrium, mitral valve, and aorta. So this is another patient with a similar disease. This is long axis view. You can see a lot of LV hypertrophy, and this is the gradient across the LVOT. So I guess I have given a lot of hint. You just have to give me the diagnosis.
Ma'am, in the left upper corner, it's not clear in apical 4-chamber, but we are seeing there is a definite membrane-like structure just from in the LVOT towards the aortic wall, and there is concentric left ventricular hypertrophy. Plus,
Yes.
in the parasternal long axis view also there is a membrane like a wedge-like structure that's present, and there is a gradient. So most likely it's a subaortic membrane that is
Right.
causing the left ventricular outflow gradient now.
So the two cases I've shown you, because here the membrane seems to be coming only from one side. On the other side, you don't see much, but in this particular case, you actually see membrane coming from both the sides. So it's a subaortic membrane. You are right. Aortic valve is likely to be normal, but often it may have some aortic regurgitation when there is severe
Right.
stenosis. And therefore, one has to look for AR also in addition to the gradient. The left ventricular hypertrophy seems much more in this case. So likelihood of gradient is higher over here, this one. And you can see in this particular case that on LVOT Doppler, there is significant aortic stenosis. So this is an important cause to be kept in mind of LVOT obstruction. The importance is that the valve tends to be spared, and therefore these patients should ideally undergo surgery earlier so that the valve can be, their own valve can be kept
Safe.
rather than letting it get damaged with aortic regurgitation. Yes, Lakshmi.
Yeah, Umesh, can you answer what are the 3 stages of a subaortic membrane? What Professor Anita has shown is just a membrane. Sometimes this is the first stage. In the second stage, it will become like a fibrous ridge. And then in the third, it will be almost like a ring, obstructing. And I have seen one with the 260 gradient across. So almost like a tunnel it becomes. And then operating on becomes very difficult. And that's why, as Professor Anita mentioned, you have to identify at this stage itself so that it can be resected. And there was a time about 30 years back, we used to do the balloon dilatation, but then we realized that that is not going to help because the aortic valve will be damaged in the future. So now the surgical resection is the best for this. Okay, there are 3 stages. It's a progressive one. Though it is congenital, it can progress. So you have to identify. And sometimes it will be very, very close to the aortic valve. So you have to look very carefully, zoom the LVOT and look for it.
So ma'am, LVOT, LV to aorta tunnel is actually a progressive form of the subaortic membrane.
Yes, yes. That's
No,
the third stage.
No. I think that's a wrong statement.
No.
LV to aorta tunnel is a
No,
separate
LV to
disease.
aorta tunnel is entirely different. That is not this. So here the subaortic
This is
membrane.
Subaortic membrane is, there is a membrane either complete or incomplete below the aortic wall. If the membrane is closer to the aortic wall, the obstruction is severe, regurgitation may be there. There is a study what the distance of the subaortic membrane to aortic wall, if it is 6 millimeter or 8 millimeter. Umesh, I want to ask you only one. Dr. Milan is asking one question.
I just a comment on what Madam Vijayalakshmi said. Just to further that, the membrane sometimes may be so close to the aortic wall that you are not able to visualize, and these patients get misdiagnosed as valvar aortic stenosis. And
Absolutely.
It's an aortic valve replacement. So
You have to do transesophageal.
Correct.
Umesh,
And
the most important question I want to ask you: what are the indications for surgery in subaortic membrane? Indications
if significant gradient and the patient is symptomatic, we'll have to go for the surgery, sir.
Do you have a lower threshold compared to the valvular stenosis? You have
Yes,
a subaortic
sir.
membrane?
Yes, sir.
So one is okay, severe LVOTO. Second, actually second is first for me.
I think others also should answer because we've got more students here. But okay, Umesh, go ahead, please.
LV dysfunction, sir. If
No, I want to know the second. Your second is actually first. You told whatever first is going to be second. Severe LVOTO is a second. First one is what is the first most important thing. Ma'am actually told during her discussion that aortic valve will be damaged.
Presence of aortic
regurgitation.
If there is any AR, mild AR or more, then you should immediately operate even if the gradients are low, because our priority is to save the aortic valve, native aortic valve. So that is one. I think I would just show you another echo.
Subaortic membrane with aortic regurgitation, mild degree is an indication for surgery. Okay.
So what does this echo, the first one, the first panel, what does this show? This is a short axis view showing pulmonary artery bifurcation, aorta in the middle. What does this show? Straightforward, simple. Anybody else wants to take it?
Other than Umesh?
Abhi?
And there is a patent ductus arteriosus.
Absolutely, you are
Very good.
absolutely right. So
Very
this is
good.
the same patient who also happens to have aortic stenosis. That's why I put it together. Same fellow had the PDA. The murmur was that of PDA. While we were trying to look for other associations before closing the PDA, we realized that there is aortic stenosis also with the trivial aortic regurgitation. So can you make that out that there is AS also, Abhik?
Yes, ma'am. There is some turbulence within the.
Right. So this is a patient who, I think what Dr. Milind was saying, sometimes the membrane is so close to the aortic valve, it looks like one of the cusps itself. So we kept on thinking that this is a bicuspid aortic valve or it is aortic stenosis for some other reason. And actually, if you see very carefully, there is in the 2D, there is actually a small membrane also. So this is also LVOT gradient, LVOT obstruction with PDA. Why I'm showing you this particular case is that if you have a PDA with LVOT obstruction, please very carefully look for a subaortic membrane, because often the cause of AS in presence of PDA is a membrane and not valvular AS. And you have to keep your eyes really open. You have to make special effort to look for a membrane in the LVOT whenever you get an AS. So we've had patients where patient had large PDA, small PDA, and some amount of turbulence across the aortic valve, and we thought it's all AS, but actually it turned out to be AS due to subaortic membrane. So this is only the message I wanted to give you based on this, that a membrane or a PDA associated with AS, think of subaortic membrane.
Can I add something, Anita?
Yes, please.
Yeah. See, what Anita has told is a very valid point. You have to remember when you are managing and look carefully. And here there appears to be some tissue there. But in practicality, when there is an aortic stenosis and PDA, what you have to do is close the PDA first and then assess the aortic stenosis. Many a times what happens is once we close the PDA, the gradient across the aortic valve comes down, so you don't have to do the balloon dilatation. So this point has to be kept in mind when you are managing the combination of PDA with aortic stenosis.
I think the basic idea is to give a full diagnosis to the patient. If obviously you wouldn't do anything for aortic stenosis if it is mild, but point is that you must remember that this aortic stenosis as well as aortic regurgitation can progress, especially AR, when there is a membrane. Nageshwar, please.
Ma'am, I just want to highlight one hemodynamic question here to the students.
Sure.
So when you are actually assessing the blood flows across the valves, in case of a patent ductus arteriosus, the blood flow across the mitral valve is equal to the blood flow across the aortic valve, which is nothing but a QS plus left to right shunt. Whereas blood flow across the pulmonary valve and blood flow across the tricuspid valve is actually QP minus left to right shunt. So I hope you understood that the blood flow across the aortic valve, nothing but the blood which is going to the body and also blood which is going to give left to right shunt. That's why echo wise, when you want to calculate QP by QS, you have to calculate blood flow across the aortic valve. Whereas in case of atrial septal defect, you have to calculate both the left to right shunt and blood flow across the pulmonary valve if you want to really quantify the shunt. Whereas VST, mitral is very important or pulmonary important. That's why your flow across the aortic valve is increased, which is causing these spuriously high gradients.
So in simple words, if you get gradient across the aortic valve in the presence of PDA, it is likely to be exaggerated. Also remember that in patients of PDA, gradient across the pulmonary valve may actually be underestimated.
Exactly.
On the other hand, it is the opposite for an ASD case. We all know that in ASD, you may get gradient across the pulmonary valve. That's responsible for the murmur also. So it is opposite of what you get in ASD. So let's move on.
Right.
This is maybe somebody else can take it. 20-year-old male, very, very simple case, followed as a large ASD. We refer to us for an ASD device closure. You can see that there is a, RV volume overload, dilated RV. The right atrium is also dilated. Both the views, long axis as well as the four chambers are showing you. Anything else you would like to point out here before I proceed? Umesh or Abik or Ishwar?
And there is PAPVC, the pulmonary vein seems to be draining into the fourth chamber.
There seems to be, what did you say? PAPVC?
Yes.
It's not, okay, ma'am, you proceed.
All right, that's okay. So I'm glad that you've recognized that there is something happening here behind the left atrium. But I wouldn't really commit on PAPVC or TAPVC because I haven't interrogated the pulmonary veins yet. But you're right, there is something happening over here, and that is what should make you suspect. And on top of that, what is happening here, which is kind of proving your point, is that there is a right to left shunt across the atrial septum. So just seeing the ASD is not enough. You have to see whether the flow is going left to right or right to left. Once you say right to left shunt, you're almost certain that this has to be T, total, not partial. Another mistake that a lot of students do in the exam is that they tend to think that TAPVC is an extreme form of PAPVC. That's absolutely incorrect. TAPVC is a cyanotic heart disease. PAPVC is an acyanotic heart disease. So all PAPVCs will still give you left to right across the ASD, whereas TAPVC gives you right to left across the ASD. So please don't think TAPVC and PAPVC, just because their names appear similar, are anyway similar. They're very, very different. And in all these cases, you will have to anyway look for the cause of TAPVC or PAPVC. Where is it draining? And this is a suppressed renal view, which immediately shows you a huge amount of blood getting into the left vertical vein. You see this red thing? So it's like, figure of 8. Upper part of figure of 8, and immediately once you make the diagnosis, you will always be looking for this, and you will definitely find. So this is not aortic arch. This is actually vertical vein, left innominate vein, and superior vena cava. Arch is actually over here. Aorta is actually over here. And of course, if one had looked at the patient's X-ray and patient's clinical examination before proceeding for the echo, you wouldn't commit this mistake. I understand in adults, sometimes getting good echo windows are difficult, but clinical examination is much easier in adults compared to children. So please don't give away the clinical examination. And this is just a humble request to all the budding cardiologists, that don't give away your stethoscope, don't give away your pulse oximeter. These are very, very important pointers. Please get an X-ray and ECG done before you proceed for an echocardiography. Otherwise, your echo is going to be wrong unnecessarily. You could make the right diagnosis just because you did not pay attention to pre-echo assessment. Diagnosis was not incorrect. And you can imagine this patient was referred to us for a device. So obviously, the person has not even looked at the this X-ray is so classical of figure of 8 kind of an X-ray. And of course, patient had a little bit, very little cyanosis. I wouldn't mind, missing this cyanosis because the saturations are rather good. But, you have to keep high index of suspicion and do a pulse oximetry. And of course, if you look at it more carefully, you see the whole chamber behind the left atrium. Dr. Lakshmi,
yeah, absolutely right. What Anita has pointed is absolutely right. Otherwise, you'll be committing a blunder. So you have to depend on your clinical examination, X-ray, and then go for the echo. So in the X-ray, Abik, what is it called as? Why is it called as the snowman in the snowstorm?
This is the vertical vein, which is draining into the innominate and the SVC, which gives rise to the snowman appearance.
Okay. Why is it called as in snowstorm? Snowman in snowstorm. That is the description. See, because of all the pulmonary veins draining to the thing, you have the plethora, plenty of plethora, and because of the venous obstruction, there can be ground glass appearance. So it appears like a snowstorm. Of course, here it is not looking like a snowstorm, but in children, especially when there is a venous obstruction, it will be like ground glass with the plethora. And that's the reason it is called as the snowman with the snowstorm. But you don't get the snowman appearance in all the cases, only in the Supracardiac you get, but intracardiac and infradiaphragmatic you don't get. So in infradiaphragmatic TAPVC, where do you look for?
There will be Scimitar sign draining into the IVC.
So again, you are making the same mistake. You are confusing infradiaphragmatic PAPVC with TAPVC. These are two totally separate entities.
Absolutely, exactly. So Scimitar syndrome is one pulmonary vein going below
Right
the
lower
diaphragm.
pulmonary vein draining into the
Rest, but the rest three are normal. So you
Normal.
don't put it as TAPVC. Exactly, this is what exactly I said. Scimitar syndrome is also a P, partial anomalous pulmonary venous connection. Infradiaphragmatic is all TAPVC. That means all the veins are again going into a common chamber and they're going below the diaphragm into the portal system or IVC or one of the liver venous system. So I'll just show you another example. Here the diagnosis is, sorry, Nageshwar, you wanted to say.
One a quick comment from me to the students, especially when you are doing neonatal echoes, obligatory right to left shunt across AST. There are three important causes. Obligatory right to left shunt across AST. One, TAPVR. Second, critical pulmonary stenosis, intact septum. Pulmonary atresia, intact septum. Tricuspid atresia. These three things you should remember. In all these three things, there will be obligatory right to left shunt will be there. Second point, I want, ma'am probably will ask, what are the saturations in chambers in TAPVR supracardiac? That probably ma'am is going to show and ask.
So I just wanted to contrast that particular case, an adult 20-year-old with a 2-week-old neonate. And it is important for you to understand that TAPVC can present at various ages. Some of these patients or some of these children actually present very early in life if they're obstructive. Typically, infradiaphragmatic are always obstructive. Even supracardiac can be obstructive. They would present much earlier in life, sometimes within a couple of days. In fact, 2 weeks may be a little older than, they may present on 3rd day, 4th day. In fact, you may get a call from the neonatal ICU that they have a child or they have a baby who looks like having ARDS. So that is how they present. Their lungs are all white. They do not have cardiomegaly. And obviously, there is no time for figure of 8 to be formed. So therefore, they would be presenting more like an ARDS. And then you have to go and do an echo and you will find severe pulmonary arterial hypertension. You will find dilated right atrium, right ventricle, severe PAH with severe TR and a right to left shunt. Again, you might say, okay, this is fitting into PPHN. This is fitting into ARDS picture. What is important here is to see whether the pulmonary veins are breaking into left atrium or not. And that is the most important part that you have to do. And sometimes when I have found it to be very difficult whether pulmonary veins are entering LA or not, because these are small neonates, sometimes you just go and do various views to look for an anomalous site of drainage. For example, suprasternal view will show you if it is a supracardiac TAPVC. Look at this. There is severe obstruction where the common pulmonary venous channel or chamber is joining the vertical vein. So this is severe obstruction, unlike the previous case that I showed you where there was lot of flow happening. Now just compare this particular flow, so much of flow, there is absolutely no obstruction. Compare it with a newborn or a neonate where you see severe obstruction. So this is usually the picture of those babies who are present in the first couple of weeks or couple of days of life, often in the NICU. You must diagnose these. If you don't find much obstruction, or let's say if you don't find flow over here, look for alternate sites of drainage. I would even look for the liver and IVC, because sometimes they may even have infradiaphragmatic obstruction, because infradiaphragmatic babies present very early in life. So TAPVC can be without obstruction, can be with obstruction. Those with obstruction are likely to present early. Those without obstruction may present early because of large flow with cardiomegaly, plethora, but they may also go on unnoticed to adult rarely. These are, of course, rare cases, and you may pick them up at the age when you usually pick up ASDs, 20 years, 18 years, going for a medical examination, going for a job and all that. So you should not think that TAPVC is a disease of children or a disease of neonates. It can be present even in older patients. So that's why I showed you two contrasting cases of echocardiography. So let's move on to
Umesh,
the other
what
one.
is hemodynamic wise? Anita is showing that. What is the hemodynamic wise and how is it caused?
Have you heard about this? Have you heard of this particular term?
vice is a membrane-like structure. I think I've not read it, ma'am, but it's
Anybody else?
a
Abhik
curtain-like
or
structure.
anyone else? No, that's not right.
Abhik? The vice is the thing where, you cut the beetle nuts or something. It is caught in between the two blades. And here you can see that Dr. Anita has shown beautifully there is an obstruction to the vertical vein. And that happens because it is compressed between the left pulmonary artery and the left bronchus. And that's how it is called as the hemodynamic vice. And you may have a continuous murmur. And these children will be, as she already mentioned, they present much earlier. So whether it is an infradiaphragmatic or supradiaphragmatic, you must look for the obstruction, whether there is a hemodynamic vice.
Okay, this is a good case. I'm not going to give you any hint. This is an 18-year-old lady who's presented in gross congestive heart failure with liver of 5 centimeters. This is stuff that the adult cardiologist should know.
The video frame rate may be slightly lower, but you can observe carefully.
I thought we had 5 students. I don't know what happened to the others.
This is apical 4-chamber view showing a large ostium secundum ASD.
Very good.
With RARB dilated and severe TR. But the mitral valve morphology also is not very clear, but ma'am, it seems like that the valve is
parachute mitral. There's only one papillary muscle visible.
This is not the view to actually comment on papillary muscle. It is a modified 4-chamber view. You have to see short axis view as well. So you can still comment on mitral valve, but if you say parachute valve, I'm not going to agree in this.
Is it mitral arcade? Because the muscle seems to be
What is mitral arcade?
Papillary muscle reaches the mitral valve leaflet and restricts its mobility.
So you're not saying that the mobility is restricted. You are talking about the various, very, very exotic language, which even your examiners may not understand. Please talk in simple language. So mitral you have to first say that the mitral valve is showing restricted motion. Why don't you say that?
Yes.
And there is trivial
it's thickened and restricted, ma'am.
Yes, so it is thick, it is restricted, showing 2 jets of trivial mitral regurgitation. Then you can think about what is the cause of it. That's a secondary thing.
Yeah. Mitral arcade, it is called as a hammock valve. It's a congenital abnormal valve, which is actually like a hammock and which causes regurgitation. There is no severe regurgitation, mitral valve.
Think of other mitral inflow abnormalities.
No, you first describe 2D, then you will understand that. Okay, that's a fairly okay. You identified mitral pathology. I'm happy for that.
So there is inadequate opening of mitral valve. So there is obviously some amount of mitral stenosis. You see hardly any flow going across the mitral valve. There is trivial mitral regurgitation. So I'm glad that you've identified that there is something wrong with the mitral valve, because very often patients of ASD, you tend to think mitral valve is not obstructed because the flow across it is fine. So would a pressure half time across the mitral valve going to help you in this patient?
There is a patient is in CHF. There is LV dysfunction.
No, there is no LV.
No. The question is, how do you assess the mitral valve severity in this case?
Normally in MS patients, you would do a pressure half time and get the mitral area. Should you do that in this case? Would it help you to give you the severity of mitral stenosis?
Because of ASD, the LA will get decompressed. So pressure half time won't help in this case now.
So what should you, planimetry, very good. So this is why it is important to understand. Even if you catheterize this patient, you may not get any gradient across the mitral valve because there is such a huge ASD. And that is the reason why the patient is in heart failure, because everything is going left to right. And therefore, there is so much TR, so much of RA-RB dilatation that patient is presenting with CHF. Otherwise, a simple, straightforward ASD would not present in CHF at 18 years of age, especially if the patient continues to be in sinus rhythm. Only arrhythmias can push them into heart failure. So this is the pressure half time. You can see that pressure half time looks wonderful. There is absolutely no mitral stenosis here. But then you do a planimetry and you realize that it is severe mitral stenosis, less than 1 centimeter square, very severe mitral stenosis. So this is very, very important because this will not be sorted out even by cardiac catheterization. You have to recognize it here. This is one place where echo scores over hemodynamics. I hope it is clear to everybody. Vijay, you wanted to add something?
Yeah, would you like to call it as Lutenbachers? Umesh?
Yes, ma'am.
What is Lutenbacher syndrome?
Ma'am, ASD with mitral stenosis of rheumatic etiology.
Here we have to find out whether this is of rheumatic etiology or...
Ma'am, the valve is thickened and the 18-year-old lady, I label it as rheumatic.
Also,
No,
there is commissural fusion.
no.
There is no commissural opening. It's commissural fusion. So mitral stenosis as it is often 99% rheumatic. And this girl is in heart failure now. Obviously, she wasn't in heart failure at birth. Otherwise, she wouldn't have gone on to 18 years. So it is in all probability, it is a rheumatic mitral stenosis. And that is what Lutenbachers is. So commissural fusion should be your answer.
Yes, okay? Yes, absolutely. See, in a parachute mitral, the papillary muscle, single papillary muscle is attached at the apex. Whereas in case of rheumatic, the papillary muscles are attached in the lateral 1/3 and 2/3, apical 1/3 and 2/3. And what happens is the commissural fusion, as Professor Anita said, because of the submitral fusion, it appears like single, but it is not single. So you have to look for the attachment. And invariably, congenital mitral stenosis will be associated with the supramitral ring also. So you have to look for the Schoen's complex. But in this case, it is, you can also see there is a pericardial effusion. That means, as Professor Anita said, the patient is in the florid congestive cardiac failure. So pericardial effusion also is there. So probably she has come a bit too late.
So the lesson to be learned here is that if you have a patient of ASD in failure, do think of mitral valve disease. I can tell you even auscultation may miss it for the simple reason that there is hardly any gradient. So you don't get an MDM also like you would have normally got in an MS. So you get all the findings of large ASD, sometimes associated with a thrill across the at the upper left sternal border because the flow is huge. Left to right is huge in these patients. So even clinically you might miss it. X-ray might miss it. ECG might miss it. It is echo that will pick it up. So it's very, very important to do a very, very careful echo in patients who are blending in heart failure with ASD and in sinus rhythm.
Very valid and very important point.
Wonderful point.
Yes, I want to make one point here. Yes. If you are hearing any murmur at a pulmonary area in patients with a large ASD, always you have to think about one is large ASD, second is ASD with mild PS, and third thing is Lutenbachers. Always, we have to always think in that way.
Dr. Tandon used to teach us that if there is a thrill in a patient of ASD at the pulmonary area, think of one of the conditions that you mentioned, PS or mitral valve disease.
Correct.
Yes.
A long systolic murmur with a thrill.
Right.
Point is that the pulmonary hypertension that you get in this case is predominantly pulmonary venous hypertension. So when you correct the mitral valve disease, most of it is going to reverse.
Right. Yes, of course. All these patients are operable, irrespective of their PVR. They're all operable.
Yes. In fact, our professor used to ask what is the effect of ASD on the mitral stenosis and what is the effect of mitral stenosis on the ASD. So that was his favorite question. So.
Right. Okay, let's go ahead then. This is ASD MS. Okay, so this is another extreme other age, 5-day-old baby in heart failure, has evidence of severe pulmonary arterial hypertension, echo done by you, nothing abnormal found. You are saying that I don't find anything unusual, there is no structural heart disease. So what is the likely possibility? The only abnormality that you have told me is that there is marked diastolic reversal in the descending thoracic aorta. Remember, this is a small baby, 5-day-old. I know it may not be something that you are very familiar with, but it's good to know it because Echo is going to be just dilated chambers, normal function, no abnormality, no ASD, no VSD, no PDA, no transposition, nothing. Patient is very minimally cyanosed because of right to left across the ASD. Some thoughts coming to your mind? Or you
Since
give
there
up?
is a diastolic, this is a flow reversal.
Mhm.
So we have to think of in 5 days or maybe any heavy malformations.
Yes, very
Wonderful,
good.
wonderful, wonderful. I'm
Wonderful.
very happy. I think I wasn't sure if you would even get it. But anyway, I'm so glad that you got it. So this baby, actually, you're right, had vein of Galen malformation, and that was responsible for the heart failure that this child was presenting in. Now I'll give you,
The
the
one
clue
clue,
was that you had to hear him over the head. So just put a stethoscope on his head, on the on right top of the head, there was a loud continuous murmur there, which is something we don't often listen to. So again, just highlighting the importance of clinical examination before you go ahead and do an echo. So in this particular case, I don't know, but the case that I saw first was that once we saw this, we went and auscultated over his head, and we found a continuous murmur, and there you had the diagnosis. Sir, somebody wanted to say something.
no, the one clue is the superior vena cava is dilated. That
Yes.
is one important point. And the second is you can see the reversal which is going into neck vessels. That is very important. Whenever reversal is going into neck vessels here up to here, that suggests that the shunt is the whatever runoff or peripheral AVM is quite significant and which is more proximal.
Right.
Absolutely. I think that is a very, very valid and important point, because flow reversal occurring in the abdominal aorta is different from what is happening, what Anita showed. So the reversal is going right up to the neck veins, and that is a very, very important point that you have to notice.
Absolutely. So this is another case who is older but behaving in the same way. 8-month-old having right atrial right ventricular dilatation with moderate tricuspid regurgitation, evidence of severe pulmonary arterial hypertension, nothing else here also. No AP window, no PDA, no AST, no TAPVC, but again there is a reversal in the descending thoracic aorta. And just to highlight the point that Dr. Nageshwar made, here the reversal is going into the arch also, unlike the previous case where it was going into the neck vessel. So this is another case where you have a similar kind of a picture, except that this child is bigger and is presenting with now dilated right atrium and right ventricle with severe TR and PAH. Is there anything that we might have missed?
Probably we need to talk. See, what are the causes for the reversal in ascending aorta? Umesh, Abhijit, Sriram, Ishwar. Reversal.
Aortic regurgitation.
Yes.
Okay.
So
AV malformation.
AV malformations. AV malformation as well.
AV malformation. Any AP window?
Aortic pulmonary window. Yes, sir.
AP window. Pulmonary artery from ascending aorta.
Causes of
PDA. So whatever the result, aorta, left ventricular tunnel, all those things. Here, suppose we are talking about a non-cardiac condition. There is a PAH, right heart is dilated. In all those conditions, left heart will be dilated. Here, right heart is dilated and pulmonary pressures are high. And 8 months baby. So what are the non-cardiac conditions of reversal of flow? Non-cardiac conditions.
Sir, in severe anemia sometimes.
Very good.
Then
rice eating state. Rice eating state.
Sir, beriberi can cause. In berry.
So beriberi, what it will cause? Why they will have that? Peripheral vasodilation. SVR will be low.
Yes.
Volume overload situation. Ma'am, you can probably.
It's a volume overload situation, beriberi that causes.
So in this particular case, this particular patient, my senior resident told me that this child has TGA. I said, how come that his saturation is 94%? There is no VSD, there is no ASD, and child has TGA. So I said, that is not possible because the saturations are too good. Now I'm giving you another hint. What would you think to be the diagnosis now? Any help with this clue? So this is the TGA. See this? This is one and this is other.
Reversal in TGA.
So this was actually a case of anomalous RPA from ascending aorta. And I can tell you, at least in my experience of 6 or 7 cases that I have seen, in at least in 5 of them, the resident has made a diagnosis of TGA without looking at the baby. I remember there was a child lying in on one of the beds in my ward, and I was making rounds, and the resident tells me this is a patient who's just had an echo, and the diagnosis has been made TGA, and that's why he's been advised admission. I looked at the child was pink. So I said, why the child is pink at 5 months with no BST, no AST? So I just told him, I said, please go back and look again. This must be anomalous RPA from aorta, because it appears as if your aorta is actually dividing. But the clue is that your great arteries are normally related. The pulmonary artery is not seen here. In a TGA, you see parallel aorta and pulmonary artery in the same view. Here you don't see it. Also, the bifurcation, it looks very odd because this seems to be one coming at an angle. The other one is the straight. So this was anomalous RPA. So please remember, any patient who has severe pulmonary artery hypertension, severe TR, you are not able to find AP window, PDA, large PDA, AR or anything, please keep this in mind. Most of these patients will again present rather early, in first 3 or 4 months of life. But in India, we know that patients come very late sometimes. And this was an 8-month-old who presented rather late. Of course, again, they're all operable, despite the fact that they have severe PH in the right pulmonary artery and even to some extent in the left pulmonary artery. They're all operable, therefore they must be offered surgical correction. So this was anomalous RPA.
X-ray may help in these.
Yes, X-ray might help. You are absolutely right, sir. It will show plethora on the right side compared to left side, definitely. But again, who looks at the X-ray these days? That is my problem. Anyway, this patient, we just, to complete the things, and this was, a case in 2005 where we were not doing too many of such cases. So we said, okay, let's study this child and get a good picture. And this, you can see the main pulmonary artery is only filling left pulmonary artery. Just to, come back to the X-ray, sometimes the plethora differentiation is not so much because all the blood coming to the right ventricle is going to the left pulmonary artery. So even the left lung may show plethora. Both the lungs may not show you too much difference between the two sides, right and left, although theoretically, right should show more plethora than the left. This is very, very simple. I just want you to see
Anita, may I add one more thing for that?
Yes,
the previous case?
Yes,
see,
please.
Whenever you see something divided like that, one thing you have to look for the truncus arteriosus, where the pulmonary artery is arising. The second is the hemitruncus, and the third one is the double aortic arch. So those are the 3 things that you have to look for before you conclude. So don't make it as TGA when the saturation is 90, 94, 95. Very good, excellent case.
Okay, this is very, very simple. This is a patient showing a big heart, severe pulmonary venous hypertension, in heart, left heart failure. This is the LV. So what are the various possibilities? 1, 2, 3, 4, 5.
And which view do you look for the clinching the diagnosis?
What is the age of the patient?
This is, I think, some 8-9 months only. Young child.
I mean, young patient.
So just give us the diagnosis of LV dysfunction. One I can give you is dilated. No, let's say dilated cardiomyopathy is number 1. Although I would like to put it as last, but I think that is what you always talk about, dilated cardiomyopathy. What else? ALCAPA. Anything else?
Ma'am, any congenital LVOT obstruction like.
Okay, so severe LVOT obstruction producing LV dysfunction.
Coarctation. Very good answer.
Yes. But remember, coarctation presents with failure in the first year or in the 30s and 40s, not in the 3-4-year-old child. So if it is a 3-4-year-old child, then coarctation is unlikely. What else?
Akayasu arthritis.
Aortoarthritis, very good. In an older child. Yes, yes, absolutely. So what you see here is that there is no LVH, there is no LV hypertrophy. So your LVOT obstructions are unlikely, but yes, that should be kept in mind. So this is the list. Something that we often forget is tachycardiomyopathy. And that is something I wanted you to say that patient's heart rate seems rather okay, doesn't appear very fast, but do think about tachycardiomyopathy, and often missed diagnosis. And these patients go on for months together as dilated cardiomyopathy. So
And
now we become
I think
Calcium
Anita
deficient.
had got the best paper award for the aortoarthritis presented as a dilated cardiomyopathy. Am I right, Anita?
you have a great memory, Vijay.
No, we were all so proud. She did it so well.
So, you know, we
Calcium
have become
deficiency.
pretty sensitive about ALCAPA now. I think you yourself have said it as the first diagnosis, but something which I want you to get more sensitive about is tachycardiomyopathy. And again, a very, very amenable, treatment amenable disease, and we often miss it. So please do keep that in mind. And these are the children whose heart rate of 180, 170 may be interpreted as normal by many of us because we think that children do have a fast heart rate, but it is the persistence of fast heart rate during sleep, during crying, during feeding at all hours that makes us feel that this is abnormal.
And when you have an echo LV like this, you know, you must go for the short axis and look for the ALCAPA. And another important clue that you can get is the glistening endocardium. If you get in the apical fourth chamber, it indicates the ischemia, and that is invariably ALCAPA. That you don't get it in the myocarditis or a cardiomyopathy. So glistening endocardium indicating ischemia should be looked for.
So why I'm showing this echo is that sometimes the coronary artery comes from this end of the pulmonary artery. So it appears almost as if it is coming from aorta. So false negative diagnosis of ALCAPA is not unusual on echo. What you have to look for is the flow. So please look at the color flow in the coronary arteries. In normal cases, this circumflex should be blue. Here it is red. So there is a reversal of flow, and that is what gives you the diagnosis that even if it is coming from this end of pulmonary artery or this wall of pulmonary artery, the flow will give away the diagnosis of ALCAPA. And to me, I would say that this is the clue. Before
Please go back. The first picture is showing a papillary muscle infarction. You can see that.
Oh, this
the
one?
first picture. Yeah,
yes,
papillary
yes.
muscle. You can see the hyperechogenicity of the papillary muscle. Yes.
Right.
So that's a very important clue there.
Yeah, very, very nice. That is the hyperechogenicity.
Yeah,
in fact, I would even, I didn't say that, but I would even go to the extent of saying the regional wall motion abnormality that you see in this particular view. This is not like a typical dilated cardiomyopathy. There is a regional flow abnormality. Same is here. You can see that there is a definite regional flow abnormality. So they're also good clue. But remember, DCM is also known to give regional valve motion abnormalities sometimes. So it's not a sort of a 100%. But also that some of these patients can actually have a reasonably good ventricular function because they have good collaterals, and they can just present with severe MR. I know of a 12-year-old boy who was being operated for severe mitral regurgitation long time ago in 1990s, and the surgeon calls me and says, "Oh, look at his right coronary artery, it is huge." So it was actually a case of ALCAPA, which we had missed and diagnosed as severe MR only. So the presentation in older patients, in older children, even adults, could be with just a severe MR with almost normal left ventricular function. The reason being that they have extensive collaterals. And that is how they survive to that age. So remember that even in a patient of MR where you don't know the diagnosis, look for coronaries. That is the message I wanted to give.
In fact, I had a 11-year-old child treated as rheumatic fever with mitral regurgitation. And I looked at the glistening endocardium and got the ECG done. And then short axis was definitely showed the ALCAPA. So you must look for the glistening endocardium, wall motion abnormality, short axis, as Professor Anita showed, the reverse flow in the coronaries, the red flow. It goes across the pulmonary artery. And these are the things to make you to not to miss the ALCAPA.
Dilated RCA can also be an additional clue.
Absolutely, that is what is showing here. So that's the first clue that you should see. And so there are patients where it looks the LCA is coming from here only, but the RCA is dilated. Patient has dilated cardiomyopathy picture. I have even catheterized some of these patients simply because I couldn't make out whether the LCA is abnormal, and because the left coronary artery was coming from this wall of the pulmonary artery. So, but I think, as I said, as we become wiser, the flow is very, very important, whether the flow is in the reverse direction or not. So all these clues can tell us. But I think before we go to the echo, here is the clue. This is the same patient's ECG, and you can see deep Q waves here deep Q waves in one AVL, and then a lot of STT changes over here. Look at V5, V5 showing us. So this is the clue. If you see infarct pattern, the diagnosis is ALCAPA, nothing else. Even if you don't show me on echo, I would still say it is ALCAPA. I would even get go to tell the surgeon to operate. I'm so confident about it. So this is a very typical pattern of ALCAPA. Okay, this is another 8-month-old came to us with, like a liver of 7 centimeter going up to the suprapubic region or right iliac fossa, and no murmur. This was the echo. This was the echo.
Ma'am,
So,
may I try?
who is answering? Umesh?
Yes, ma'am. Yes, sir.
Oh, okay, Umesh. So,
So there are, yes, sir. So please.
yeah, you tell me what are the additional investigation which you want to actually see. Investigation means in the clinical examination, ECG, X-ray. Apart from echo, what is the
Okay.
additional one which you want to?
Ma'am, sir, ECG will be helpful.
What is the
Because there is,
diagnosis you are thinking of?
sir, I'm thinking of any, ma'am, storage disorder, because there is glistening, thickened myocardium that is visible.
So what is storage disorder?
Glycogen storage disorder in this 8-month-old with CHF with hepatomegaly can be.
So what is that? What is that in this age group? Which is storage disorder?
Gauss.
Can you name one? The most common one.
Most common one which has got cardiac manifestation.
Starting with the A.
Pompis.
So what are the ECG changes of Pompis disease?
There will be biventricular hypertrophy.
More important than that, biventricular hypertrophy will be present even in hypertrophic cardiomyopathy in children, in Noonans, for example. What is glaring in this? You can see this ECG. So not just biventricular hypertrophy, something more important.
What is the interval?
Short PR
yes,
interval.
Yes. So please look for short PR. That is far more important than simple biventricular hypertrophy. There are
So what is the PR
biventricular.
interval in this ECG?
So it's almost less than between 60 to 80. So it's very
short.
Very short, sir.
Less than 100 milliseconds.
Yes. So that is what is very, very important. Biventricular hypertrophy with short PR. It's quite classical of Pompis.
Yes.
Right? Is it
Would
treatable?
you like to think in terms of amyloidosis?
Amyloidosis in such young baby, I'll not consider it now.
You should not, and also I think look at interatrial. No, interatrial septum tends to be thick in amyloidosis, but you are right. In a child of 8 months, I would not even think about amyloidosis. Sure. Is this disease treatable? It's a question to be asked from pediatricians, I suppose.
Some enzyme replacement therapies have been.
Enzyme replacement therapy, you should be given less than 2 months of age. If you give 8 months, it won't work actually. So generally they present with drooling of saliva, hypotonia, generalized hypotonia, delayed milestones will be there, and hoarseness of voice. Okay, so please.
After all this, one very simple one. I think if there is another student besides you and Abhik, then we'll be happy to.
Dr. Sriram, can you take this?
Dr. Sriram is muted. I think. Yes,
yes,
Dr. Sriram, can you, without putting your video on, can you take this one? This is a very simple one. 6-year-old being followed up as small VSD has been asked to come every year and has been asked to have good dental hygiene. What do you see?
What is your plan of management?
Are you there?
Yeah, Sriram opened his camera.
Yes. Ma'am, actually the video is getting stuck. I have some net issue.
No, now I can see it is running very nicely.
His video, I think, is his. Do we have any other student? I see Dr. Sunil PMC07@gmail.com. Can you please unmute yourself?
Yes, ma'am.
Can you read this and can you answer what Dr. Nageshwara has asked? What is your plan?
Yeah, ma'am, looks like aortic valve cusp prolapse. We should go
Very
for
good. Very good.
Excellent.
What else?
VSD is looks restrictive, ma'am, at present because due to cusp prolapse.
Very good.
Okay,
And
wonderful.
any other finding on echo besides this, besides prolapse?
Any shadow there?
Can you read color flow mapping?
There is
Whenever you have aortic valve
ex-
prolapse, what are you worried about? Let it prolapse.
eccentric aortic regurgitating jet is said that, no?
Yes, ma'am. Yes, ma'am.
Sridhar? Okay,
Yes.
what is the cause for the prolapse? What is that
Does-
mechanism called as? What is the Venturi effect?
Ma'am, it's suck the
Venturi.
valve. Yes, ma'am. It suck the valves towards the flow, ma'am.
So does this
when there is a
AR
gross,
bother you? Does this AR bother you?
there is a risk of infective endocarditis in these patients. They
Why?
can develop vegetation.
Also looks like
That-
vegetation present, ma'am. I think.
So no, this patient is a small VSD. Now the VSD has become quite small because of prolapse.
Yes,
What do you want to
Yeah.
do? Do you want to do anything or you want to go with the same advice?
No, ma'am.
This is an indication. This is an indication to operate immediately because the started to and there is
More than
significant
valve
aortic
prolapse, what is there? What is the?
regurgitation.
Yes.
They were at a risk of failure and
Why would there be failure? VSD is small, AR is
small
trivial.
vegetation.
Where is the
So
vegetation? There is
we
no
are giving you
vegetation.
diagnosis. There is a small VST and aortic cusp prolapse, and there is a mild AR. So how do you want to? What do you want to do for this case? Straight answer. Straight question. There is a mild AR, clinically not audible AR, BP wise normal BP, small VST, and aortic cusp prolapse. What is your management? Umesh, you can answer, Umesh.
I would advise to
He needs to unmute their video. There is a lot of
Umesh,
background.
Madam Anita already she told the child was in a follow-up. And during the follow-up, they have found out this, the aortic regurgitation. Once you find the aortic regurgitation, you are not going to follow up, you know. You have to send for the surgery because actually when the cusp prolapse is lifted, the VSC will be much larger than what we are seeing in the echo. And you are underestimating the VST because of the cusp prolapse. It is like giving you an impression that it's a small VST. In fact, it will be a bigger VST and it has to go for surgery once the aortic regurgitation is detected.
Otherwise, you're going to lose the aortic valve.
Yeah.
See, the whole idea is to keep your native aortic valve in place.
Preserve
And that
it,
is why
preserve
this
it.
is the time to go for surgery rather than wait for AR to progress. Once AR becomes
Absolutely.
severe, it will not come back. So this is a very good indication for surgery to preserve aortic valve. And of course, as Dr. Vijay Lakshmi said, this VSD is actually pretty large. And the surgeons always will come and tell you, oh, you said it's a small VSD, it's a large VSD. Once I lifted the aortic cusp, the VSD was huge. So therefore, it is not a small VSD, but it has been restricted by aortic valve prolapse. And now that there is AR, don't wait anymore.
That is a very important learning point for all of you. Though you are following up the patient, once the AR appears, you are not going to wait anymore. Okay?
Small interruption. My question to Nageshwar sir. So can such type of VSDs are amenable to the device closure?
It's absolutely contraindicated because you are entrapping the aortic cusp within the device. It will further enhance the aortic regurgitation. Even if there is no aortic regurgitation, if you want to close in the presence of aortic cusp prolapse and no retroaortic subaortic rim, it's a contraindicated. So we should not close. It's absolute indication for surgery because AR is a progressive phenomena. Your all efforts should preserve the aortic wall. Unfortunately, you cannot auscultate trivial to mild ARs. That's the reason we have to do careful echocardiogram. Don't tell any people that you auscultate for AR. If you find auscultable AR, that's already valve is getting damaged.
Right.
I have one
Yeah.
question also for the panel. Suppose we have a perimembranous traditional VSD versus an outlet type of VSD. Would the threshold for intervention in AR be different?
Yes.
No, I would say that any AR in outlet or subaortic VSD should be operated. But if it is a perimembranous VSD with no AR, then you will follow them up.
Oh.
An outlet VSD in any case should be closed because it never closes on its own. So this is for Abhik, an adult, 40-year-old with dyspnea, bicuspid aortic valve, aortic regurgitation, and a huge dilated left ventricle. And here are the MCQs. This is simpler.
There seems to be a very turbulent jet coming from the aorta back into the LV.
You have 5 differential diagnoses. Choose one.
The clue is regurgitant jet is from where is it coming?
From the RCC cusp.
You should also look at the 2D picture before seeing the color only. This is the aortic valve, this is aorta, but then there is something happening here.
Aortico-left ventricle tunnel, ma'am.
So your answer is B.
B.
Not aortic dissection. Umesh?
Yes, ma'am. I'll also.
Is it valvular regurgitation or paravalvular regurgitation?
Paravalvular, sir. Paravalvular.
Native paravalvular regurgitation. Okay.
Right. So you're absolutely right. In fact, there is a little bit of valvular regurg also. See this jet? See this jet? So this is, and this is quite common because aortic valve geometry gets disturbed. So you may have a valvular AR also to some extent, but then the dominant jet is paravalvular, and it is actually an aortic-left ventricular tunnel. A 40-year-old man who's dyspneic has a bicuspid aortic valve and severe. Clinically, they will behave like severe aortic regurgitation. So this was, I would say, rather simple. Now, these are 4
What is the
set of
clinical
questions.
examination finding? What is the auscultatory finding in this patient? Anybody? What is the auscultatory finding? You will have tone flow murmur. You have systolo-diastolic murmur.
You may only have diastolic murmur, Dr. Nagesh, because there is, there's hardly anything happening in systole. It's very little. This is like a murmur of AR. It will behave like murmur of AR.
And the tunnel can be closed with the device. Need not send for the surgery if the AR is trivial.
But you have to be very sure about coronaries, where they
Correct. Absolutely.
Nageshwar,
Yeah.
what do you say about device closure?
No, we have published actually 7 cases series. Only selective cases can go for surgery, not all cases. Sometimes it will be large and aortic distortion, aortic wall distortion. Ma'am published one article, I know, Vijayalakshmi ma'am published one of the first article. But you have to carefully select the case for the device closure.
So I think your answer should be that case has to be evaluated whether device can be done or not. It's not the usual garden variety like an ASD, VSD where you can close with a device. So this is for Abhik. There are 4 set of questions, 4 questions rather, and you can keep answering 1, 2, 3, and 4. So what does arrow 1? This is a PR jet. I presume you all can see that. What does arrow 1 and 2 indicate, and which pulmonary artery pressures would you be able to derive out of it?
Arrow 1 indicates early diastolic pressure. If we add RA,
okay, please
go ahead.
If we add RA pressure to it, we can get the pulmonary artery mean diastolic pressure.
Okay.
And arrow 2 indicates end diastolic pressure, ma'am.
Okay.
Okay.
What
does
does
this
it
patient has pulmonary hypertension?
Yes, ma'am.
Yes. See, this is
Or
the
meters.
velocity that you can see.
60.
The last question is enumerate 2 more ways of assessment of pulmonary artery pressure by Doppler echocardiography.
we can see the pulmonary valve acceleration time
Very
and
good.
also from the TR jet.
Very good. You got all 4 right.
Hmm.
I think you're absolutely right. You've answered all the questions. Okay. 12-year-old being followed up as RHD, severe mitral regurgitation, undergoes an echo. Do you find it's all fine? It's RHD, or do you think of something else? Umesh.
Ma'am, mitral valve prolapse. It looks like Barlow's disease.
Is that Umesh?
No, ma'am.
This is Sunil. Anybody wants to take another go? Because that's a wrong diagnosis.
Look at the valves very carefully. Look at the ventricles also very carefully.
You got the clue.
And also look at from where the jet is coming.
there
Is it coming from the orifice or somewhere else?
Coming from here, no? There is a
Is it a cleft
No,
mitral?
no,
No, not
let us
cleft.
not go with the color. First, you read the 2D
Yes.
fourth chamber view.
Very important. I
Apical
think
2D
Nageshwar
fourth
is,
chamber view is important.
I think it's very, very important that don't jump onto color. I've seen residents just jumping onto color, putting
Yes.
the image and putting the color. Please don't do that. You will remember when you put color, the frame rate goes down dramatically. So please try to see, look at the frame rate here, 61, and look at the frame rate here, 17. So obviously your clarity here is much less than here. So please do look at the 2D image, which you have a much better frame rate.
Yeah.
Ma'am,
It's a commonly missed condition. Please, you must answer this.
Yes, Umesh, you were saying
Ma'am, it's
something?
an apical four chamber.
defect in the anterior
Yes.
Yes, very good. Defect 4 chamber view. Yes.
Apical four chamber view
Yes.
with dilated left ventricle,
Okay.
showing
The left.
a cleft like of mitral valve, ma'am, being
Yeah, this
there are
frame.
two separates.
Do you
There are two
think this is
separates.
mitral valve? Do you think
This
this
is
is
a
mitral
beautiful
valve?
frame. Beautiful frame.
This is
There
mitral
are
valve.
two.
Look at the
Yeah.
valves and the ventricles carefully.
This is a tricuspid valve. This is a mitral valve. Is that what you're saying?
What is the AV valve offsetting?
Madam is giving you the answer of what more do you need.
Where is it attached? And where is the moderator band?
Actually the
Moderator
one
band
on the
is-
right up, the valve which is on the left side up.
Now you got it. Now you got it. So which is this valve? Tricuspid or mitral?
tricuspid.
This is tricuspid one.
This is
Tricuspid valve.
tricuspid. So here is the clue. This is the clue. Of course, you can then corroborate it by saying that this ventricle is hypertrophic, this ventricle is tuberculated, there is a moderator band. But this is where the exact, all your money is. If you don't look at this, then everything else is missed because everything else is soft data. But look at this hard data. Tricuspid is here, mitral is here. And now you can switch over to the color and see the jet, the way jet is going. It's so abnormal because it's a tri-leaflet valve, tricuspid valve. That's why your jet is very different from what you normally get in rheumatic. So this
Another
is a
thing is that
patient
the valve is septophilic. You can see that. The
right,
left AV valve.
absolutely, yeah. So this
So-
is just a corrected transposition with severe regurgitation of the systemic ventricle valve, which is tricuspid valve morphologically, and this is morphologically right ventricle.
What are the commonly associated lesions with the CTGV? Mahesh?
Umesh.
Yeah, Umesh.
Right
You-
sided aortic arch.
Don't be happy with just making the CTGB. You have to look for something else. What are the things?
Dr. Sunil, you were saying something. What are the association?
Right sided aortic arch, ma'am.
No. It's an L post aorta, so it can't be right-sided aortic arch.
Right side, common
AV
thing.
valve
which are
regurgitations are common. AV valve
Which-
regurgitations.
That's right. What else?
Umesh,
More common than
Umesh.
AV valve regurgitation.
They have VSTs. Do they have-
SVSDs.
Who is answering, Umesh or
We would
somebody?
like to look at the rhythm, whether
No, Umesh, there is a style in answering this question. You have to tell structural, functional, electrical. Okay. Structural,
Absolutely.
what are the structural association, functional association, electrical association? Very simple.
CHD होता है.
Structurally,
VST and PS, pulmonary
aortic-
stenosis and
aortic-
VST are the structural that you have to look for.
Yes, ma'am.
Almost 80% of them will have associated VST or pulmonary stenosis. Then electrical, why did you say electrical? In
CHD.
a given day, a CTGV patient can have tachyarrhythmia or bradyarrhythmias. Why? Why are they prone for the tachybradyarrhythmias?
What is the incidence of complete heart block in CTGA?
30 to 40%.
What is the percentage per year? How they progress to develop?
2% per year.
Nobody has it at the beginning. No? It can occur later in life also.
So 2% per patient years.
Yes, sir.
So
Okay.
what are the other conduction disturbances? Ma'am already asked you. Okay.
There is an accessory AV node, no?
Pathway option.
So what
What are the
happens?
functional abnormalities? Functional is the number one, systemic ventricular dysfunction, and second is the systemic AV valve regurgitation. These are the two functional. Okay.
There is bowing of the base of the interventricular septum towards the right-sided ventricle, and therefore there is incomplete coaptation of the systemic AV valve. So that is the reason why it is so commonly incompetent in these patients.
Very good.
Also, you can also have Ebstein's kind of malformation, and that could also, that's pretty common actually.
Yes.
Okay, this is a very, very small child, 4 weeks old, who has presented to us with, in emergency actually, with severe cyanosis and a lot of respiratory distress. So you're thinking in terms of TGA because that's a common diagnosis, but this is what the echo shows when the patient came for an echocardiogram.
Somebody needs to mute their video. There is a lot of audio background sound.
I think. Okay, go ahead. Umesh or Abhik or Sunil. I don't know. The fourth one is probably not Dr. Ishwaran, Sriram Ishwaran. I think he's got some issues with his net. I would request all the students to, to have a good net available. Otherwise, this whole exercise becomes quite dull. So Umesh and Abhik, you are the only two who have good Wi-Fi. Can you read this echo rather than make a diagnosis?
This is an apical 4-chamber view.
Okay.
Showing
this is right ventricle. This is left ventricle, left atrium, right atrium.
Dilated,
anything unusual?
Thickened LV cavity, thickened myocardium, as well as there is an hyperechoic shadow in the RV apex also, ma'am.
This
look
one?
at the interatrial septum. Just look at the interatrial.
There is an ASG also, ma'am.
What is the size of the ventricle? What do you call that?
This is the mitral valve. This is the tricuspid valve. Do you see anything unusual here? This left ventricle looks normal to you, except hypertrophic.
This is severely hypertrophic.
And the size is okay. Mitral annulus is okay. Mitral annulus size is okay.
What is that called?
No, ma'am.
Hypoplastic.
The annulus size seems to be smaller, ma'am.
So this is typical hypoplastic left ventricle. I don't know if you won't call this hypoplastic left ventricle. What will you call hypoplastic left ventricle? Have you heard of hypoplastic left ventricle syndrome?
Yes, ma'am.
This is what it is. Small mitral valve, restrictive PFO, dilated left atrium, small left ventricle, grossly hypertrophied, not contracting well. This is all. There's nothing, no other diagnosis other than that.
Despite cyanosis, there is an obligatory left to right shunt through the.
Generally, because they would have an interruption also or severe coarctation. So the PDA is supplying in fact, they often have aortic atresia or aortic stenosis. So the whole of systemic circulation is actually supplied by PDA, and that is why they are blue. They're quite blue actually.
So baby is living till 4 weeks of age. 4 weeks, how baby will live? There are only two shunts which is important. One is ductus arteriosus, which is supplying the systemic circulation. Second is
AST.
The foramina oval. AST, intraatrial communication. It is quite restrictive. You can see that.
So it sometimes restricts over a period of time as the baby gets older. But majority of the cases, Dr. Nagarsh is absolutely right. These babies are done in first 2 or 3 days. If you don't do anything, they wouldn't survive that
Absolutely.
much.
Mortality is very high.
Very high.
Nageshwar Rao, I had a very interesting case where The coronaries were arising from pulmonary artery, though there was a aortic atresia. And that's how the child survived till the 4th week. Very interesting. So nature
Very
is...
unusual. Yeah. Yeah. Okay, this is a big child, a big girl, 17-year-old, being followed up as VST, large, with Eisenmenger syndrome. But what worries us is her saturation. Usually at 17 years in Eisenmenger, you don't get so much desaturation. 72% is rather on the lower side. Generally, they would be in their 80s most of the time. So there was something amiss in this girl, and that's why we thought there is something more than what is happening. Look at the right to left shunt, very little, hardly any, but her saturation is 72%. So we did this color also. And is there anything you can pick up on color? There is a large VSD. You can see this large VSD, which is, I mean, going bidirectional perhaps. And you know from contrast echo that it is going a little bit right to left also.
Abnormal pulmonary vein drainage is there.
Very good. Drainage or something else? It's draining into LA. No, it's draining into LA. Connection is normal. What else?
There is turbulent flow over there. Maybe pulmonary vein stenosis.
Yes. So please use your words carefully. This is a pulmonary vein which is going into left atrium. How can it have abnormal connection? That is where it is supposed to go.
Yes.
So this is actually
Stenosis.
turbulence in the pulmonary vein, and you will put a Doppler and you will find a continuous signal. The gradient may be 10 or 12, but look at the continuity of the signal. It's not reaching baseline at all, suggestive of severe obstruction. And this girl, actually, we dilated pulmonary vein. I know it's not a very good idea to dilate pulmonary vein, but we didn't have much option. So we dilated her pulmonary vein, and her saturation improved to 88%. So she was VSD Eisenmenger, but at least her saturation improved, so her symptoms became better. So do look for unusual associations, even in a straightforward case such as Eisenmenger syndrome. So let me just quickly go through a couple of more images because we are running out of time. This one. These are just, echocardiographic, what should I say, curiosities that we sometimes come across. Asymptomatic, 25-year-old, undergoing an echo, found something, then they did a transesophageal echo as a routine. Anyone? These are not the garden variety that you're going to see every day.
When there is a echogenic mass attached to
what are the differential diagnosis?
So it's a right coronary cusp, a very, very well circumscribed echocardiogenic mass attached to right coronary cusp. What is the DD? What is the differential diagnosis or the first diagnosis?
It is seems to attach to the valve, so I first keep it fibrillostoma.
Very good, absolutely. That is what it turned out to be at surgery. That is what it turned out to be at surgeries. We'll be quick now. Short axis of one of the
quadricuspid valve, ma'am. Quadricuspid valve.
Possible possibilities.
Quadricuspid.
Where is it found? Truncus arteriosus.
Truncus arteriosus.
So one is truncus, but remember there is a rare entity called quadricuspid aortic valve. Yes.
Without
so
truncus
you can,
also.
you can have an aortic
normal
valve.
human being also quadricuspid is extremely rarely reported.
Yes, it's reported, and some of these patients may present with AR, aortic regurgitation.
Yeah.
Spot diagnosis. Concentrate on this one.
Parachute mitral.
Little better.
What is that?
Madam is showing you. VJ is showing
mitral
you.
valve you said, but you missed that in your mitral valve case.
In the last echo session,
double outlet mitral valve.
Absolutely. Double orifice. It is called double orifice mitral valve, not double outlet mitral valve. 10-day-old neonate presenting with cyanosis, long axis, and 4-chamber view. Lungs is quite normal. You can see that LV is normal, mitral valve is normal, but this is where the abnormality is. I've given you the diagnosis. There is hypoplastic, I showed you hypoplastic left ventricle. This is hypoplastic right ventricle. And when you have hypoplastic right ventricle, it could be either tricuspid atresia, but since you have a tricuspid valve, however small it is more likely to be pulmonary atresia with intact ventricular septum where LRV does not develop very well. Okay. I think, should I stop? Dr. Milind?
Since you already this slide is there, you can stop after this.
Okay, so this is supravalvular, yes, just to give you a,
No, that the child figure is important.
yeah, so this is Williams syndrome child,
Yeah.
where you get, so you see a look at the child and you get a clue that this is likely to be, this was also being diagnosed as valvular AS with AR, there is AR also here. So, but when you look at the child, you know that you're probably dealing with supravalvular or Williams syndrome, as we call it.
Elfin faces.
Elfin faces.
Okay, okay.
With
I'm just
patulous
going
lips
to,
and mal-occluded
Right,
teeth
right.
and all that.
and this is for you, Umesh, for fun. Last one. A ball, a cricket ball in the heart.
Cricket
ball
ball
was-
or football or a
It's a-
pumpkin.
There is no pedunculated attachment, ma'am. It's a ball thrombus. I'll go for it.
What is the diagnosis? Why is there a thrombus?
What is the mitral valve?
Why should anybody develop a thrombus?
The
When do you
mitral
get
valve
LA
normal.
thrombus? When do you get LA thrombus?
Umesh, what is the Virchow's triad? You have
Chassis,
to have at least one of
hypercoagulability.
them, no? Yeah.
Chassis, hypercoagulability, and one moment.
Very basic question.
Then, ma'am, it's a
Either there has to be stasis or endothelial
Hypercoagulability.
damage or hypercoagulability. So what is here?
But
Most
what is
of
the
the-
basic diagnosis? There is a ball valve. I thought this was for fun.
Hmm.
It's a big
Ball, but you are not appreciating
Mitral
mitral
stenosis?
stenosis. Why are
I
you not
gave you
appreciating
two also,
mitral
mitral
stenosis?
valve.
See, you should
Then
not be
atrial
carried away
fibrillation
by the
also.
most. Let me tell you the details, or let's say the diagnosis hidden in some of the subtle findings. This is very obvious. Anybody, I'm sure, if a student of class 12 will also tell you that there is a huge ball inside the heart. As a cardiologist, you need to know why there is a huge ball inside the heart.
Because of
There
the
is mitral
stasis,
stenosis.
mitral stenosis.
There's such severe mitral stenosis obvious in both the views, which you missed. Convinced or not convinced? Umesh, not convinced?
And the wall seems to, there is no severe stenosis in the.
No, the mitral valve is totally restrictive. Actually, you can
For me,
see
there is
very
a anterior
carefully
node.
here.
See, you see the PML is restricted, AML is so thick, and
Doming.
then doming. So it's a
Anyway,
mitral stenosis.
Yeah,
It's
this
actually
is a
severe
similar
mitral
Patient
mitral.
is also in atrial fibrillation.
Yes, yes. This is severe mitral stenosis. No doubt about that. I think that is the first thing you should. And whenever you see LA throm or mass in LA, look for mitral stenosis. In our country, how can we afford not to?
Correct. Absolutely.
Okay, I think I'm going to stop here because we've exceeded our time already.
Okay.
So
I
I'll
think
stop
we must
sharing.
be very grateful to Anita. Wonderful cases, had real nice feast of cases.
Thanks to Vijay and Nageshwar for
Thank you,
making
ma'am.
it so
Wonderful
live.
Dr. Milind
For
and
making
Ajay.
it so live.
Superb
Yeah,
cases,
thank
ma'am.
you.
Superb.
Thank you.
Superb cases.
Okay, then. Thank you,
Request
ma'am.
for closing remarks from Dr. Nageshwar Rao, sir, from the panel.
Actually, it has been a really wonderful session. The only one important point I want to give is students should actively participate. We should have panel of students other side, at least half a dozen students, or students should keep posting the questions so that the presenter will have enthusiasm. So next time we will have more student interaction because there are wonderful cases. We wanted to ask a lot of questions, lot of interaction. That small point is missing. But they tried. Probably their internet connectivity is not really good. But I thank ma'am for showing illustrative cases, many of the illustrative cases. And this is a great opportunity, Milind. You made it, and Dr. Ajay and other people, Sir Dr. Kunu Agarwal, and did very well. Fantastic job. Thank you.
Yeah, Dr. Milind, I request you. Dr. Milind, can you hear me?
Yes, yes.
Yeah.
Yeah, so it has been a wonderful session. This is the third one and very enjoyable. And Madam has shown all the echoes possible, probably which you could be shown as spotters. and from your clinical point of view, which you will come across in your day-to-day practice, and you should know as clinicians. She has shown the common errors that can be made in diagnosis, how a TAPVC is misdiagnosis and ASD, how a CCTGA is misdiagnosed as a rheumatic AR. I mean, these are things we see in day-to-day practice. So there is nothing very exotic in this, just simple things which can be missed. And all, I mean, it has been a feast of pediatric cardiology. And I would like to give it over to Dr. Ajay Mahajan, sir, for a summary of the session and any comments.
It's really very, very great feast for listening to this, all the three big names in pediatric cardiology. And today I learned a lot, and I hope everybody learned a lot today. With this, I will request all the three panelists to give us another chance, so that we'll ask them to come up with one additional session for the students and for everybody's benefit. Thank you.
Before you close, I just would like to thank both the students who have been very brave, and I think you've really played very well the game. I wish there were more, and I would request Mr. Agarwal to sort of ensure that the students, if they are participating, then they should probably have a good Wi-Fi connection. Otherwise, it gets very disruptive.
Yeah.
And these days, getting a good Wi-Fi is not something that is a choice. All of us have to have it.
Absolutely.
Yeah. So I think we are living in a world where Wi-Fi is our life.
Absolutely.
So anyway, thank you, Abik, and thank you, Umesh.
Of course, not more important than wife, but Wi-Fi is there.
Yes.
Good.
Any parting remark, Ma'am Vijay Lakshmi, please, if you have.
No, it was a wonderful session, and Anita is a master in teaching, and she did absolutely well. And of course, Nageshwar Rao also contributed so well. I think as Dr. Nageshwar Rao said, the more students' participation, the interaction, the question and answers, they come only when the other person is speaking well. And that's how, better to have more number of students with connectivity. And those who are not connected also can post their questions. And Nageshwar Rao, one interesting thing I would like to tell regarding the aortoventricular tunnel. In fact, when I closed the aortoventricular tunnel, Dr. Kurt Ampler sent me 3 devices free of cost.
Oh my God.
Three devices free of cost. And then I first put the AST device. It was too big. I removed it. Then I put the VST device. It was blocking the aortic valve. I removed it. And then I put the 16 by 14 PDA device. Though it was not big, it was small. So ended up with the hemodialysis for 5 days. And that is the first ever case of aortoventricular tunnel closed by device. And 35 years before, Kurt Ampler was in the group of Lily High who operated on a aortoventricular tunnel and put a Evanon plug inside that. So when I asked Kurt, give me some advice, he said, Vijay, nobody can advise as nobody has experience. Use your clinical acumen and all the best. So that was his email, So clinical acumen is very, very important for anything. Even before examining the echo, we have to have the clinical diagnosis, clinical assessment. And wish you all the best for all the postgraduates. And the teachers are always there. And we are not only teaching, we are learning in the course. So it was a wonderful session. Thank you, one and all. Thank you very much.
Thank you.
Shubharatri.
Thank you. Thank you, sir. Once again,
Thank you.
really convey our heartfelt thanks to all our esteemed panelists and presenter, Ma'am Anita Ma'am, Dr. Vijay Lakshmi, as well as Dr. Nageshwar Rao, and nicely moderating Dr. Ajay Mahajan as well as Milind Khatke. So really sincere thanks to all my esteemed doctors and also participants. As ma'am already told, please wholeheartedly participate with your questions. I think it's a great learning opportunity. We shouldn't miss out because many people aspire to have this kind of sessions. Those who are not getting this kind of illuminating, kind of session. So I request all participate wholeheartedly, make this program successful. With that positive note, let's conclude the day. Thanks once again. Have a good night. Thank you, ma'am.
Good night.
Thank you, sir.
Thank you, sir.
Thank you. Thank you.